I think the biggest question in the next few years is we can see if you bring these treatments up earlier, the treatments that are approved for MCRPC, that they may have a more profound impact. That may or may not be true for some of the newer treatments that have been approved for MCRPC, things like abiraterone or enzalutamide or radium-223 for that matter. Those are the things that should be tested in the same population and will be tested in randomized trials over the next few years. The real question is, can we substitute those for the benefit of chemotherapy with docetaxel? We don't know the answer yet. So for now, in general, given the power and the magnitude of the benefit of early docetaxel in HSPC, or hormone-sensitive prostate cancer, I would suggest that we'll learn more about whether drugs like Abi or Enza could substitute for chemo, but for now, it's really not an option. This is one of the most profound survival benefits we have seen in metastatic prostate cancer that I've seen basically in my entire career. So while I'm very excited about the new treatments in castration-resistant prostate cancer, I would really, really strongly urge the physicians, and in particular because they don't always see these patients, to talk to their urological colleagues to really refer these patients for early chemo. The other thing I would really emphasize is that many of these men are older, but they may be very fit. And while some doctors are concerned about giving chemotherapy, for me there's really no upper limit of age for who I would give chemotherapy to. Many of the patients I've been treating recently are in their 80s. I've given chemo to men in their 90s. It all depends on their physiologic age, and you can always give this chemotherapy if you think their risk of dying of cancer is high enough to justify the relative survival benefit.